Oh, go ahead. Okay. Good afternoon. Thank you for joining us for the August 2nd, 2024 meeting of the Chicago Teachers Pension Health Insurance Committee. For the record, I am Jeffrey Blackwell, President of the Chicago Teachers Pension Fund, and I've been asked to lead the meeting by Chair Mary Sharon Riley, who is joining us remotely. The meeting is being held in person at our office at 425 South Financial Place. The Health Insurance Committee includes 5 CTPF trustees, and a quorum for this committee is 3 trustees on site. Committee members include myself, Lois Nelson, Maria J. Rodriguez, Tammy F. Vincent, and Chair Mary Sharon Riley. Please note the following. Access instructions for remote attendance and instructions for in-person attendance have been posted on the fund's website. All participants, please wait to be recognized by the chair before speaking, and please limit discussion from each trustee to 3 minutes. Please note that for our staff and trustees to focus on the business of the meeting, we will not be responding to messages from participants using the Zoom chat feature. Please forward questions to memberservices@ctpf.org. We will now move to public participation. Do we have any members of the public who wish to be heard? Okay, move from that. Now we can move on to roll call.
Trustee Blackwell,
Present.
Trustee Nelson, Trustee Riley, Trustee Rodriguez,
Present.
and Trustee Vincent.
Present.
Thank you.
Okay, thank you. We have a quorum as required by the Open Meetings Act. We'll now vote to approve trustee remote attendance and full participation. The Open Meetings Act allows for remote participation by a trustee if a quorum is physically present, which for the committee is 3 members, and a member cannot physically attend due to personal illness or disability, employment, public body business, family, and other emergencies or unexpected child care obligations. Trustee Riley has asked to participate remotely. Trustee Riley, please confirm that you are attending due to one of the exceptions previously listed.
Yes, I'm injured, so I can't get down there.
Okay, thank you. I will now entertain a motion and a second from a trustee who's participating in person to allow Trustee Riley to fully participate in the meeting. Can I second? I can, second.
Roll call.
Mhm.
Trustee Blackwell,
Yes.
Trustee Rodriguez,
Yes.
and Trustee Vincent.
Yes.
Thank you.
Okay, thank you. The motion passes and Trustee Riley will be a full participant in the meeting.
Thank you.
Thank you. Do we need to? Okay,
I'll do a roll call of other.
okay, yeah, the other,
And I mean, it's not necessary per se, because the committee is the committee.
Okay.
Theoretically, the other people are just kind of members of the public, but I know that's been your longstanding practice, so go ahead.
Is your mic on? Attorney, is your mic on? Yeah, I could barely hear.
Sorry about that.
Oh, thank you so
So,
much.
yeah, go ahead and do it. I know you guys list them in the minutes. So if you didn't list them in the minutes, I tell you didn't have to do it. Since you list them in the minutes, go ahead.
should we wait? Because yeah, that's what, if,
Are they coming in or are they?
I don't know.
They may linger in.
I
Yeah,
mean, yeah, that's what I was
we'll
saying.
just note, you'll
Can we
make a
note it at the end
notation
of the-
that they came in at certain times.
Okay. Okay, now she's been promoted. We will now move to item 4, approval of the minutes. Do I have a motion to approve the minutes from May 3rd, 2024? Second.
Trustee Blackwell,
Yes.
Trustee Riley,
Yes,
Trustee Rodriguez,
No.
and Trustee Vincent.
Yes.
Thank you. 3 ayes, 1 nay.
Okay, thank you. And that takes us to 5, January 1st, 2025, final renewal actions and recommendations. We will now move to agenda 5, which is the final renewal actions and recommendations. That'll be presented by our consultant Siegel.
Hello,
Good afternoon.
good afternoon, everyone. So you take a look at this, should be on the screen. Yep. I'm going to talk about the January 1, 2025 rules as we know them today. Similar format for those of you who've been here in previous years. We're going to do a quick summary overall first, and then talk about the Medicare and then the non-Medicare. So on page 3, summary of results, you can see the different plans for the Medicare on the top portion of the page here. You've got the Humana Medicare Advantage HMO that includes drugs. That is an 11.3% increase. That is a preliminary increase. The final increase will be available before the board meeting, but we don't think it's going to be very much different than that. And you can see we have the enrollments, the number of contracts also there on the right, just for your information. So a little bit less than 500. Express Scripts prescription drugs, that is a 28.3% increase. That affects everybody that's in the AARP Medicare Supplement Plan, the UHC Medicare Advantage Medical Plan, and the Cigna Surround Plan. Now that looks like a pretty high number, and it is a pretty high number. There's 2 reasons for that. One is the impact of the Inflation Reduction Act, which we had discussed in March, legislation that made the benefit enhanced for members going forward. And the second reason is increased utilization of brand and specialty medications. And this is not just an issue for the fund. This is actually an issue for most of our clients. And we're going to see later in the presentation that although that 28% is high, it's actually in line with what others are seeing this year. The Medicare Advantage plan, that is no increase. That's a $0 premium, if you recall, and that's not going up. The Medicare Advantage Plan F, as usual, that's a little odd because that's an individual market plan and the fund has no control over those rate increases. And they vary by age and geography. And then the Cigna Surround Plan, which is the new program that was introduced for 2024, intended to mirror Medigap Plan G for people that were not eligible for F. That's an 8.3% increase this year. On the non-Medicare side, the HMO through Blue Cross, 2.6% increase. And the Blue Cross Blue Shield consolidated PPO, which is combining the UHC PPO and the Blue Cross PPO, that is a decrease of almost 13%. So let's get into a little bit more detail here on page 5, starting with Humana. Again, this rate here of $145.63 for a pensioner. It's not the final rate, it's preliminary, but we expect the final rate to be pretty close to that. And that's the 11.3% increase going from $130.84 to $145.63. Keep in mind that all the rates we're looking at right now are the total rate. So we're not talking about splitting it into the portions yet that are being paid by the pensioners versus the fund. We will get into that on the last slide so that you can see what the impact is. But right now we're just talking about the increase in the total rate that the carrier is asking for. Okay. Page 6, Express Scripts. So this is the prescription drug component of most of your plans. Right now it's at $1.8042 for pensioners, and it will be increasing to $231.46. And again, there's multiple reasons for that. The Inflation Reduction Act and the increased utilization of brand and specialty medications. Page 7, we look at the United Healthcare Medicare Advantage. So the top portion of that table is the medical part of the plan, which does not have drugs in it. That's the $0 premium portion, and it's going to remain at $0. So that's awesome. Then you add in the drug portion on the table below. And since you add $0 to the drugs, you just get the drug rate. So that's the 180.42 going up to 231.46 again. So that's your 28.3% increase in the drugs since the medical is contributing $0. Page 8, as we've talked about before, it's a little complicated with the AARP Medicare Supplement Plan F because It's an individual market plan, and their rates change usually for most people on June 1st. And so those folks, they see a rate change that occurs June 1st, and then January 1st, there's a rate change for the prescription drug rate changing. And so as of June 1st, 2024, the rates for just the medical component of that supplement plan, that's that 304.44, that's an average rate. As we talked about, there's really a different rate for all different kinds of people. But if you take the average, that's what it looks like. And that's not increasing in January. But if you go to the bottom of the table, the prescription drug portion, when that gets added, that portion will increase just like everyone else's. And so when you add the two pieces together, it's a 10.5% increase that will be occurring at January 1st because of the drugs. Page 9, the Cigna Surround. This is the new plan for 1124. Current premium 159.31, excluding the drugs, just the medical component. That's going up 8.3%. And then if you include the drugs, that goes up to 18.9% because the drugs are increasing by 28% and the medical is increasing by 8%. And so when you blend the two together, you end up with a number that's in between those. So that brings us to the non-Medicare groups. On page 11, we have the Blue Cross Blue Shield HMO, and that is a 2.6% increase. So going up about $28 a month in total premium for a single person. And then on page 12, we've got the Blue Cross Blue Shield, which is now a consolidated PPO program. The current premium here is a blend of the current premiums for Blue Cross and UHC. And if you compare that to the renewal premium, it's a 12.9% reduction, almost $1 million reduction in total premium. On page 13, we kind of take a look at all the plans combined by Medicare and non-Medicare. So the non-Medicare, if you combine the 2-something% increase for the HMO with a minus 12.9% increase for the PPO, you get a negative 6.3. So reduction of 6.3% in the total non-Medicare. And of course, in the Medicare, you get a much higher number because the drugs are dominating a lot of that. It's 27.8% for the Medicare plans. Those calculations always exclude the AARP in the calculations because they increase at a different time of year and there's a different rate for everybody. And then if you look at all the retiree plans together, the non-Medicare and the Medicare, you obviously get something in between the 6.3 negative and the 27.8. You obviously have a lot more Medicare folks, so you get a number that's 18.6, which is closer to the 27. Now, all of the rates are the same plan designs in terms of deductibles, co-pays, co-insurances, with the exception of the non-Medicare PPO, which we know is consolidated between the Blue Cross and UHC designs. All of the other plan designs are identical to what they are in 2024. The AARP supplement, as in past years, we won't know what that June 125 increase is until then, but we do know what the January increase is for the drugs. And the non-Medicare, the main reason for that reduction is the RFP that the board authorized the end of last year, and that we presented the results of to you earlier this year. Now, the increase in Medicare premiums is mainly due to the prescription drugs with Express Scripts. And as we talked about, the reasons for that are the Inflation Reduction Act impact and the additional utilization of brand and specialty utilization of brand and specialty medications. Now, I want to show you what current industry trend looks like on these things so you have something to benchmark against. So non-Medicare medical is going up about 7%, and Medicare medical is going up about 5%. So, if you look at yours, your non-Medicare went up 2% for one plan and negative 13 for the other. So that's very nice. The Medicare medical, your UHC plan, the Medicare Advantage went up $0. It's still a $0 premium. Your Cigna, which not a lot of people are in, but it's a brand new plan, and there will be presumably more people in it as time goes by. That went up 8.3%, so a little bit higher, but because it's a small group, sometimes it's a little bit higher increase. And then, of course, the AARP program went up, but not nearly as much as the drugs, which went up 28%. Now, how does that 28% compare to the market? Well, just prescription drugs, if it weren't for the Inflation Reduction Act, is a 12% increase in the market. But of course, that 28% that we've been talking about includes both the Inflation Reduction Act and the increased utilization of specialty medications. So when you look at both of those combined, and we look across our client base and across the industry, we've been seeing 25 to 35% increases for 2025 from 2024. So 28% is a very high increase, no question about it, but it's not, there's definitely worse out there. You're on the lower half of what clients are actually seeing for that. So if we go to page 14, if we look at by plan, what we were able to save in negotiations, the first three plans were already under guarantees. The Humana plan and the United Healthcare Medicare Advantage plan. The Express Scripts is under pricing guarantees, not rate guarantees. And the Cigna Surround plan and the HMO, those were the initial renewals. We're not able to get any additional money off those, but we were able to, through the RFP, get almost $1 million off the PPO. So that's a good chunk of savings right there. So the question is on page 15, what would these increases mean to the actual pensioner in terms of if it was hypothetically still a 60% subsidy, like it is in 2024, if that's the same number in 2025, how much monthly does it affect a pensioner? And so that's what we're looking at on page 15. For the non-Medicare on top, you can see the Blue Cross Blue Shield HMO is about an $11 increase. The PPO is a $355 reduction. And that's for folks who are coming from the Blue Cross PPO into the new consolidated Blue Cross PPO. For folks coming into the Blue Cross PPO from the old UHC PPO, it's an increase of $97, but they're also getting a much richer plan than the UHC plan was. Better deductibles, better copays, et cetera. On the Medicare side, the United Healthcare Medicare Advantage is an increase of $20.42. AARP, the same. And that's because they are getting basically what the prescription drug increase is. And then the Humana HMO is a smaller increase. Again, that's not final, but it should be close. And then the Medicare Cigna Surround Medicare Supplement Plan G, $26. So a little bit higher for them. So that's any questions?
I have a question for the executive director. How are we, or did we already start notifying everybody about the Blue Cross Blue Shield? Or they'd already kicked in the consolidation? Page 15.
The board approved the Blue Cross Blue Shield consolidation.
Some of the acoustics are bad. So you talk a little louder.
Sure. The board approved the Blue Cross Blue Shield consolidation at the Health Insurance Committee in May, and then the full board took up the vote. So that has been approved. Let me check with Carrie in terms of what's been sent to the membership.
So we have publicized it, but we are actually sending independent letters to the members that are in the UHC, giving them direction, as well as the members that are in the Blue Cross. So they will each get an individualized letter that are in the PPOs. And then we're also off.
Will be, because it hasn't been voted on.
We were waiting till the
Okay, yeah,
so we
that's
could
what I
give
mean.
them
So it
with
hasn't
the
been sent
subsidy.
out yet. Okay.
Correct. And then we're actually going to have a special special webinar for them
All right.
in September 26th.
Okay. So back to, okay, so that's great, the webinar, but remember, if you recall, there's always been that concern of some of the more seasoned retirees that do not use the internet. Are we ever going to go back to in-person doing these seminars? Because part of the reason we moved here was because were you here? I don't know, maybe. Yeah, that the downstairs, the third floor, whatever was going to be used to do those seminars. And actually, we had two when we first moved in. So people are crying and begging and texting and email me saying, when are we going to be able to attend in person? They want to see your lovely faces. They want to see you, and internet and everything. There's nothing like meeting face to face with staff. Is there any way we can do that or arrange that?
We are in the final contract negotiations with the folks at Hilton down in Oak Lawn, and we will be
Okay.
having conversations.
Good
Will be,
news. I'm
yes.
glad I asked. No, they do. They
We
feel
didn't want to
more
publicize it
confident.
till the contract was signed, but yes,
They
it'll
feel
be
much
very
more
soon.
confident. Perfect. Thank you. Good question, trustee Rodriguez. And I got a good answer. Thank you. Thank you.
Go ahead, Casey.
So, good afternoon. So I am assuming that I'm not understanding some of this. Well, let me rephrase. I have questions. I understand it, but I want to make sure that I'm understanding what I'm understanding, because maybe I'm not understanding. So, when we talk about the, where is it? There was a price that you quoted. Okay, so like for the Medicare, the drug, so is one of the premium for the monthly health insurance, does one of them include the price of the prescription drugs in it? Is that what I'm
Yes, so
understanding?
it
that?
depends on which slide you're looking at. So for example,
Okay.
if you're looking at slide 7,
Mhm.
and 8 is the same way, and 9 is the same way. The top table is just the medical component. The bottom table is the medical plus the drugs.
Got it. Okay.
So that's why on the top table on page 7, because there's a 0 premium for the Medicare Advantage with UHC, that's why those are 0. But then you add in the same 180 we've seen on page 6 for a pensioner, and that's why it's 0 plus 180 is just the 180 for this year, and then for next year it would be 231.46, just like it showed on the previous page for the drugs.
Okay. And then, so like the AARP Medicare Supplemental F, that is its own plan? Or is that tethered to, like because when I hear supplemental, I'm thinking like, I know Medicare has like a Part A and something, I don't know. There we go. So, but this is a F here, so I guess I'm trying to understand, what does that connect to? Does that connect to the monthly, like the regular Medicare? Because I know some of it pays for the doctor, and then one pays for I guess the hospitalization and all that stuff. So how does this AARP F, is this the same? Does this connect to this other stuff, or this is its own plan with like medical and prescription and doctor and all that?
So think of it like this. There's 2 different pieces to your plan. There's the
Mhm.
medical piece and the drug piece, okay?
Right.
For all your plans, except the Humana one, where they're combined, for all your other plans, they're 2 separate components that are getting added together. So the Medicare Supplement Plan F, for example, that is something that people get from AARP with United Healthcare, and it just covers the medical stuff, the Part A and B stuff in
Okay.
Medicare. In order to get their drugs covered, Medicare Part D stuff, that's where the Express Scripts gets added on. Okay?
Okay.
And the same thing happens if instead of taking the Supplement Plan F, if they want to take the UHC Medicare Advantage plan, the UHC Medicare Advantage part is the one that replaces Medicare A and B and does the medical portion. And again, Express Scripts, that same Express Scripts piece gets added on to do the drug portion that also got added on to AARP Plan F. Same thing for the Cygnus Surround plan. The Cigna Surround Plan is a plan that supplements just the medical portion, the A and B Medicare stuff. And then you add on the prescription drug portion separately, which is the Express Scripts stuff. So the only exception to all that on the Medicare side is on page 5, for those 500 people that selected the Humana Medicare Advantage plan, that one integrates drugs within the Humana plan. So
Okay.
for them, they don't get Express Scripts. They get their drugs through Humana, and they knew that when they selected it. And so that's why, one of the reasons why it's a lower rate for them. And, they've looked into the network and decided that, that rate is worth it for them based on where their doctors are and who's in the network, et cetera.
Okay.
So hopefully that helps.
I had one more question. So correct me if I'm wrong, wasn't there a plan that we had that people were no longer able to enroll in?
F.
That's Plan F,
So it's
the
close.
AARP one?
Yes.
Yeah.
Okay.
So it's, and this was a federal law. This isn't something that the fund decided to do.
Right.
The Fed said that no one is allowed in Medicare, in Medigap Plan F after 11/20. Yeah.
Yep.
And so what folks said is, well, we'd like there to be an option besides the Humana option and the UHC Medicare Advantage option. We'd like there to be some supplement plan option for people that were blocked out of Medicare F. And that's why that Cigna Surround plan was introduced 11/24, which mirrors what Medigap Plan G looks like. But it's a group plan as opposed to being an individual plan. That way, it's a rate that the fund negotiates and has some control over in the plan design, as opposed to an individual plan, which has a different rate for everybody because it's on the individual market.
Got you. Cool. Thank you.
No.
Let me finish up.
Oh.
What? They were done with that.
Oh, you were done with that part?
Yeah, we're done with it.
Go ahead, Lauren. You had a question, Karen?
Yes. So here's my question. This is what I look at a glance. So we look at page 3 and you've got, what you find, page 3, you have Blue Cross and Blue Shield, consolidate PPO. It seems when the numbers, you've got people with the one above it, Blue Cross Blue Shield, HMO, 353, but when you have a lesser number, 301, then you get a decrease, correct? Am I reading that, interpreting it?
That's just the number of people in the plan. So it's not really related to the two columns aren't really related, other than it's just
Yeah,
telling.
I guess I'm looking at the premium change. Yeah, that's, I'm looking at premium change. Are you looking at it, Carrie? You look puzzled.
Yeah, no, I.
Oh, you're up there. Okay, sorry. Yeah,
I
I
was looking
see
at it.
that a decrease for 12.9%. And then I'm looking, am I stating it right, Mitch? Can you follow me? You look puzzled too. Maybe I'm not saying it right. Does anybody on?
So I think the 12.9% is a consolidated using the former UHC PPO and the Blue Cross PPO
So
members.
when it's consolidated, it'll drop.
So, correct. So as we know from our conversations back in May,
Uh-huh.
the members in UHC will actually pay a little more. They're going to pay about $96, I think, before the subsidy. And maybe after the subsidy, actually, after the subsidy, I'm doing this off the
But
top of my
they're
head.
also getting an improved plan over what they had before.
Correct.
Right.
And then the Blue Cross folks are actually paying quite a bit less.
Yeah, because I just
After
want to
the
make sure, same thing if I'm looking at page 12, it appears, but I'm glad you explained, that's why I'm asking questions, so I clearly understand it. When there's lesser number, when there's a smaller number of people enrolled in that particular plan, it seems like the rates are decreased. I'm looking at.
No,
page-
it doesn't have to
That's
be
what I'm
that way.
saying.
It
That's
just
what I'm
happens
asking.
to be that way this year because because the non-Medicare, you have a lot less of those people.
Okay,
And this was a good year for non-Medicare, partly because we went to RFP for the non-Medicare plans, which we presented earlier this year. And also partly because on the Medicare side, you had the Inflation Reduction Act impact as a headwind and increased use of specialty drugs as a headwind.
yeah.
So you're right, it does look like there's a correlation because
Okay.
the smaller groups did
But it was
better
a
this year.
decrease in enrollment, not so much, yeah.
It's just their enrollment is smaller in the non-Medicare because you're over 65 for a lot longer than you are under 65 usually. And it just so happens that this year there were more headwinds on the Medicare market side than there were on the non-Medicare.
Okay, thank you.
Move on to the next one.
Okay, so we can move on to the forecasting, please.
Do you want, are we taking the action item?
No, there's no action there.
Okay, okay.
We will actually,
Okay.
should I just go ahead? They haven't put up the forecast.
Yeah, she went back to the teller.
Got it, okay. So the forecasting will be coming up. You should have that in front of you. So I'll go ahead and start and then they'll bring that up momentarily. But our expenditures were a little less than 67.7 million this past fiscal year. When you look at the accruals included, as you can see, it's pretty tiny on the screen, but you can see it about mid-page. If you're looking at that, we did create several different forecasting models and we're showing you two today. And I'm going to talk a little bit about those. The first one is us staying at the current 60%. And that's the first row towards the bottom in the middle of the page. And the second one is actually remaining at 60% for 2025. But as you will see with our expenses continuing to grow and rise, and it's really becomes unsustainable to stay at 60% by the year 2030. We're going to discuss ways that we can maintain a plan to consider for the future. The plan on the right shows the options such as dropping the subsidy to 50%, implementing a $250 deductible to the Medicare members in Express Scripts who are using brand drugs for 2026. And changing the formulary for 2027. And as you can see by the forecasting, we do show that we'll be under 65 million as of 7/1/26, which is why we are proposing some changes. As such, you'll see in the board action request, we are recommending remaining at 60% for this year. In the event you have questions, we can definitely address them before we go on to the bar where I'll talk more about the recommendations.
Okay, so I think you're saying that if we stay at 60%, it's not sustainable for very long.
Right.
So one of the ways to balance that is those calling for a name brand, which the consequence of going for a name brand without adding a charge to it would be that they pay a higher price for that instead of the generic. And then on top of it, we would add a charge, possibly discouraging that, or if they want to pay it, they pay it. And part of that would help balance it to keep it at 60, or still we're looking at reducing it from under 60, because you mentioned the 50. You said a whole lot in a little bit of time though, so I just want to make sure I followed you there.
I did say a lot. We are looking at all different options, and I'm actually going to talk about in the bar that we're even looking at possibly speaking with the lobbyists about reviewing the $65 million statute limit because it hasn't been updated since 2004. But in the forecasting model, we're really kind of talking about next year for that year. And then we put in a bunch of different options. And one of the ones that you mentioned is the 250. That is a proposal out there that any person taking a brand drug would be given an additional $250 that they would have to pay for that brand drug.
What does the statute encourage? What?
It's 65 million every year is what we receive through the statute.
Okay, so
Yeah.
that guarantees that we'll get 65 from the state.
Correct.
Okay.
How far back? Oh,
Point. And, Jack.
So I think I just heard you say that we need more money from the state in order to maintain the 60%, right? And how much did you say that would be to maintain the 60%? Or did you give a number?
I did not give a number
Oh,
for the
okay.
statute.
So if you just had to, for kicks and giggles, give a number. You got one? Oh, of course you
Yeah.
do. Okay, so we'll talk. Okay.
We put it in the bar as something to discuss, but about 83 million is what we're thinking.
So we should just go for 100? Is that what I heard you say?
So is it my turn?
Yeah, go ahead.
Okay, this right here, y'all remember how big fight? This is gonna be a big fight if you take that 60% away. So I think the better option is to go for more money, but I have been talking about this for the longest. It has been over a decade, well, a decade.
Two decades.
Oh, yeah, 2 decades.
20 years.
That we have been, 65 million is not what it was worth 20 years ago.
Correct.
So I think that, then we should add this to our legislative, agenda. And we should just say 100. I say double. Because then we can maybe go to that 70%. If we get it double. And I think that so much calculated over 2 decades, I mean, we should ask for, so that would mean we were asking for 50 million for per decade. Healthcare cost goes up every year. We have a very good rationale to make with that statement, so I'm thinking that I think that going backwards is not an option. You're gonna have people up in arms, and I'm gonna be one of them because I'll probably be retired. And you know, I'm very outspoken, so, yeah, because I'm looking for it to get better, not worse.
Absolutely.
Yeah, COLA.
That's the plan too.
The statute?
No.
No.
I think
You mean
that,
adding the COLA to what they're sending from the state?
yes, yes,
the-
yes.
An inflation adjustment.
Yeah,
Okay.
exactly. Because this has been 20
They're
years.
setting you up.
So I think that they owe us money because inflation, come on, everything is high. And healthcare, without a doubt, goes up every year.
Absolutely.
You're absolutely right, and she's got it covered in the bar.
Maybe we should just get to it.
Should I start on the bar?
Yeah.
Was there?
Yeah. No, you know what, but something, okay, yeah, something we keep in mind, and it was something I've said for years and years, nobody believed it. Just like the pension pickup, I said, you know, that's in the union contract, that may change one day. And this thing with the 65 million, and they're talking, there's an article today of even merger, there has to be some way to figure it out.
Yeah, they will probably want to take the 3%. It's gonna be a deal, the annual
Yeah.
3%.
Okay.
That, Carrie,
no, no,
that's
no.
the end, that's it.
I was just trying to let Jeff know that trustee Riley has her hand up as well.
Okay.
Historically, the reason we didn't ask for more is when Madigan was in power, he wouldn't give it to us. Because I think his thought was that the fund should not even pay for health insurance at all.
Well,
So that's why it's been so long since we've asked. So
Well,
he's not in power anymore, so, but we're using fund
Used to,
assets.
They
to
separated
cover it.
now, the state handles it.
Yep.
Now.
that changed.
Or are we? No, I think we got it from the state now.
They're giving us the money and we administer ours. And honestly, we get better
Tammy, you
rates
have-
than the state does.
I did. So I think Mary Sharon might have just alluded to what I was asking because there was like a pension holiday for years. And I know that led to the underfunding. How was this impacted by that? Or is it like just 2 different revenue streams and they have
Two
nothing to
different
do with it?
things, but what happened, we kept raising it. In fact, when it first started, it was $3 million a year. And it got up to 65. But when Madigan was in power, he didn't think we should have anything. And then the state started paying for it. Carlton, am I right?
That's correct, Mary Sharon. State started paying for it in
So
2017.
I guess we have to ask the state to increase it.
Correct.
So it's a little different process than it used to be. Okay,
Go ahead,
thank
Gwen.
you.
Thank you, Mayor.
So one more quick question. thinking about these dollars. So they've been given 65 million since 2004.
Correct.
So you probably have this in this thingy that I'm half looking at this moment, but do we know how the dollar's spent? So 65 million in 2004, what was it paying for versus 65 million today? So like, then I guess I'm asking now so we know, well, I guess actually you already know that answer because you had a number in your mind, because I want to know what should be the inflationary cost that we are actually seeking so that the rate is the same. You know what I'm saying? So whatever we had in 2004, whatever that 65 million bought in 2004, 85 million or 100 million would be able to buy in 2025, or, and so on and so forth. I guess that's my question. I don't know if it was clear.
Actually, we want to work with the lobbyist to potentially create not only an increased amount, but then actually have it grow.
Yeah.
By the
Percentage increase, annual.
Indexing.
Indexing.
Index, yeah.
Okay.
In 2004, the fund was paying it, not the state, but now the state is paying it.
Yeah, just be
And
aware, I think you're the
that was
only,
just, that's not even 10 years ago that started.
What'd you say, Joe?
I think Carlton can maybe confirm this, but I think you're the only pension fund that gets that. So, that's going to be your fight. You
Yeah.
know, just be aware, like TRS doesn't get it as SERS, no one else gets that million.
Yeah, but aren't they covered by the same health insurance, everybody?
Yeah, all of the other systems are covered by CMS at the state level.
Right.
So they got a much bigger group rate is what you're saying.
Right.
Yeah.
And
You
they
can go ahead.
change it all the time.
You got a question?
Central management system is the state's
Yeah.
insurance department.
They don't have to go through all this. This CMS is already,
They have a separate process where they petition the General Assembly each year for how much their budget is going to be to cover insurance. Yeah.
okay, simpler. We don't know if it's better or worse care, but it's already in place, which means they don't have to fight
Every
all
year
the
for-
time. Okay.
Go ahead, and we go, get back, because I think they're gonna answer a lot of questions.
That's a very valid point, with, what the state has. Thank you for adding that additional information. However, we have always been segregated. So keep on segregating us and give us some more money. I think they have always, we have our own school code because of our size. So this is how you started this. This is how it was always started. And now I think that, I know it would probably be less of a benefit going into CMS. I don't know anything about CMS. I'm just assuming because they have let us do this forever and see if everybody else has been in CMS. So let's keep it that way and just go for more money.
Jeff?
Go ahead, Mary.
Remember, though, we're the only school district that has to fund our own pension system. The state funds the rest of them, so their school budgets don't have the pension system. And as far as the healthcare, they change it more often, but I have friends who are in it and they're not dissatisfied with it. So anyway, just a little bit of information.
Thank you. The history, you always got that for us. So
I was just really curious. So when she was saying at Madigan, so Madigan was just against, I guess historically, funding the CTPF because we were separate from the other
No.
folks? Or?
No, that's not what it
They're
was.
funding it.
No, it was
I understand,
health-
but if theirs is funded by, if the other systems is funded by the state and CTPF is, I guess, essentially self-funding, what was the issue?
I'm talking just the health insurance, and he didn't think the fund should use our funds to pay for health insurance. And that's a while back.
Go ahead, Mary.
But then the state started paying the 65.
Are you trying to
When
respond
Chuck
to
Burbridge
what Tammy's
was here.
asking?
most recent, we've had, not anyway, trustees who've said we shouldn't be in the business for health insurance. It's on tape. Not anyone present right now, not anyone present. They've said.
Maria,
that,
you're
so-
not using your mic.
Sorry, I said thank you, I apologize. Most recent, we've had trustees, no one present here right now, who have said that we should not be in the business of health insurance, that we should go out there and get our own health insurance. So it's not just Madigan. There's been a lot of confusion. There's a
Well, they
lot
were
of
wrong.
catacomb, but can we move on or?
What are you gonna say, Jeff?
No, I was just wondering, was there ever an option for CTPF to be in CMS?
That I know of, no, that I recall,
Oh, that,
no,
I don't recall that.
no.
Okay.
But
You can go
oh,
continue. Go ahead and continue.
Okay, can we bring up the bar, please? So the pension code limits the amount to defray the member health insurance cost to 65 million, as we've been discussing annually, plus the carryover from the previous year. At the end of the fiscal year 24, the carryover insurance spending authority was estimated to be about 63.6 million. And there was estimated to be about 67.7 million in program expenses. So based on these results, the staff recommends that the board authorize a 60% subsidy for the calendar year 2025. The forecasting forward, though, CTPF may have to consider really lowering the subsidy in subsequent years, as we've been discussing. Market trends show that health insurance expenses are increasing overall based on several factors, including the Inflation Reduction Act, utilization of brands and specialty medications, as well as inflation. So given that, let's talk about the trend analysis and strategy for calendar year 26 and later. The statutory allocation, as we've discussed, is 65 million. It's been that since 2004. We've really worked diligently to make sure that we sustain high quality, low cost coverage, as well as keeping our cost increases below industry trend during the last 20 years, which is pretty impressive. The actions we have taken have been implementing a group Medicare Advantage plan, instituting negotiations with our pharmacy benefit manager, conducting multiple competitive bids via request for proposals. All of these actions have allowed the fund to continue to move forward with no increasing to the funding level until now. Current forecasting model shows the expected increase in expenses in fiscal year 25 and beyond. The current subsidy percentage is really not sustainable for future years unless CTPF can secure increases to the $65 million statutory allocation. CTPF will be working towards the goal with Siegel and our lobbyists in the upcoming months, as index rates will be requested to keep up with inflation and to reduce the need to request more funding in the future. Some of the expected increases in plan cost is due to the change in the funding model as part of the Inflation Reduction Act.
They can't get into board docs.
You gotta mute,
However,
Mary Sharon.
Mute, yeah.
however, a significant,
Mute, Mary.
No, she's muted.
she did. However, a significant portion of the expected increases are related to the increase in utilization of brand and specialty medications by our members. As such, the CTPF health insurance team will be working with Express Scripts and the CTPF communications team to make them aware that they may have lower cost options that are effective alternatives for the medication they are currently using. If CTPF cannot secure increased funding in the next year, there will be several options that will be considered to ensure continued financial stability under the current statutory allocation. CTPF will be looking at lowering the subsidy, potentially adding a deductible for brand medications, as well as adopting a formulary change. So with that, we're going to talk, if you can move to the premium increase, please. Premium changes for 25 each year. As you are aware, the health insurance premium rates are evaluated for the next calendar year. Our carriers, Blue Cross Blue Shield, UHC, United Healthcare, excuse me, Humana, AARP, UHC, Cigna, Express Scripts, they reviewed the past year's claims to determine the rates for the following year. The non-Medicare rates were previously approved at the May 16th, 2024 board meeting. The Medicare negotiated rates are being presented to the committee for approval today. The Medicare rates, if you could scroll, oh, you're at Medicare, thank you very much. Medicare plans, the Humana rate shows as TBD. We did talk about the 145.63, I believe.
Yep.
It will be determined before the board meeting, the exact dollar amount of that. UHC premium is $0, as we've discussed. AARP Medicare supplement, a number of 304.44. That's an average, as you are aware. Express Scripts, we're recommending 231.46. And the Cigna Surround plan is 172.57. And I'll talk through each of those. The Humana Group HMO plan provided a preliminary premium rate of 145.63, which is an increase of 11.3%. The final rate will be provided before the board meeting, as I mentioned. AARP Plan F premium rate will remain constant until 6/1 of 25, when the premium rate increases can be expected. Premiums increased generally on June 1st, increased on June 1st with an average rate of 13.2%. And those rates are determined by the state departments of insurance and are based on age and geographical location. Amounts are shown just as illustrative purposes for the board or for the committee. Express Scripts premiums are increasing by 28.3%. And of course, this impacts our United Healthcare Medicare Advantage PPO, our AARP Medicare Supplement Plan F, and our Cigna Surround Group Supplement Plan. And last but not least, our Cigna Surround Group Supplement premium rate is increasing by 8.3%. So now moving on to the non-Medicare, which, as I mentioned, were approved at the May 16th board meeting. The HMO, Blue Cross Blue Shield HMO plan is the unsubsidized rate is 1123.62. The Blue Cross Consolidated, this is a new plan, is 1654.11. Blue Cross's HMO premium rate is increasing by 2.6%, and the consolidated weighted plan is decreasing by 12.9%, and that is a weighted average between our current members in our Blue Cross and our UHC PPO plan. And just to note, the Medicare Part A, which is for our members that have a retirement pre 7/1/2016, and our Part B rates are not provided by CMS, Centers for Medicare and Medicaid Services. Until October, the 60% subsidy would automatically apply to these benefits as well. So given that, the recommendation, based on the analysis and projections, staff recommends continuing the subsidy of the annuitant health insurance cost at 60% and approving the renewal rates for the calendar year 2025. Staff will continue to do our due diligence and reevaluate the reserve and subsidy levels on at least an annual basis. Thank you.
Quick question. Carrie, so then under the Medicare plan, Humana Group, HMO, PD1 to be determined. So would that mean that if we vote for your recommendation on the report, but we would be voting on something that's still to be determined and we do not know that number just yet until October, I believe you said?
We will actually know that before the next board meeting in August, and it will not exceed that 145.63.
It will be what, I'm sorry?
It will not exceed that 145.63 that was in the SEQL presentation.
Okay, all right.
So it'll be lower than that, but because of the Inflation Reduction Act, they have been
145
waiting on guidance from CMS.
Will not
which
exceed
caused the delay.
145.63, correct?
Correct. I
Thank
believe
you.
that's the number that I'm doing that off the top of my
believe,
head,
yeah.
but yes.
Yeah, you have.
Yes,
Victor?
thank you.
Well, just, I think when you said due diligence, I mean, you want something better, but until that happens, so the talk of getting something done through the state legislature, it's more Hail Mary than anything else. So you have to do what you got to do up until something comes up that will rescue us in another way.
Thank you.
Yeah.
Anyone else?
Any questions?
Yep.
I can ask my questions offline. Just need a motion, to approve, because you have that as an action.
Yes. Okay, so, need a motion to approve. Motion made by trustee Vincent. Was there a second?
Correct.
So it's the
Both.
motion
And
to-
renewal.
To continue the subsidy at 60% and improve the renewal rates for calendar year.
Oh, I can second it. That's right. I forgot I can second stuff today. Second it. I forget I can participate today.
Roll call. Trustee Blackwell,
Yes.
trustee Riley,
Yes.
trustee Rodriguez,
No, not at this time until we have that actual number in place. So I'll probably vote yes at the full board meeting. So no from right now.
trustee Vincent.
Yes.
Thank you. 3 ayes, 1 nay.
Thank you.
Thank you.
Thank you.
Thank you.
Takes us to 7, unfinished
Have a good
business.
weekend.
Oh, we got another presentation?
No.
Oh, I was going to say, I'm trying to get out of here. Unfinished business? New business? Motion to adjourn?
Motion to adjourn, if I may.
You may.
Thank you.
Second. Maria made the motion to adjourn.
Roll call. Trustee Blackwell,
Yes.
trustee Riley,
Yes.
trustee Rodriguez,
Yes.
and trustee Vincent.
Yes.
Thank you.
Okay, Victor. 1 hour. Victor.
That's it. That's my, that's what we gotta go. It's not like if we're gonna get.